it really kind of dovetails into this next sequence I want to talk about, and that is around sequencing and around some of the other novel agents that we haven't necessarily studied in the context of, say, CARD, but follow that same paradigm, meaning it's a mechanistic switch. We're not going from one hormonal agent to another, but from one modality to another. And that would be radiopharmaceuticals. And in particular for today, that's radium-223. That may be something different in the future, but for today, radium-223 is really kind of a unique class of agent in terms of being an alpha particle, in terms of really being a targeted therapy towards bone. And in thinking about it mechanistically, it's not tied, genetically to any phenotype. It can kill indiscriminately, regardless of RB status or P53 status or what have you. So in thinking about radium-223, where do you sequence that now in the context of your chemotherapies, of your hormonal therapies? Where do you sort of see that falling optimally? Chuck, do you have any thoughts on that?
Well, you brought up a really interesting point, which is, and this come up a couple times now, is we are our field is dividing our therapies into the precision therapies and the imprecision therapies, and both have value. Killing indiscriminately is the way you put it, and that's a good thing, right? So I think that's one of the key ways we need to think about things. When do we need a targeted therapy? Early, AR, PARP if it's a BRCA, et cetera. But like it or not, occasionally our patients, and more than occasionally, our patients get into a situation where they have disseminated disease that we don't know what the biology is. And this is where radium-223 kind of fits in. I'm typically using it in the symptomatic patient with obviously predominant bony disease, no visceral disease, or patients who have no option for chemotherapy available to them. So it is typically being done with a palliative intent, a survival intent, and it's very well tolerated. And that's one of the areas that it has its greatest value. As we continue the conversation about imprecision therapy, we may see a growth in what other radiopharmaceuticals, and whether there is if you will, a marriage of targeted therapy and imprecision therapy and targeted radiopharmaceuticals, which is another area. But for now, radium is considered a standard option for patients with bony disease who have pain typically and bony predominant disease.
And Tanya, do you think this follows the same paradigm as the other drugs? Meaning, when we use it in high volume, later heavily pretreated patients, maybe like where it was studied with Alsimca, we see some benefit. But if we move it earlier in the disease, where the disease burden is less, we might see proportionally greater clinical benefit?
Yeah, that's a good point. Certainly, there were toxicity analyses looking at giving radium before or after chemotherapy, because you always want to be playing chess with your patients and making sure that you're not closing doors and, what are my next 3 moves, and not just what's this next move for this patient today. And once a patient has anemia, certainly, which can happen as the disease burden gets greater, they don't tolerate the radium. They may not finish the 6-dose course. And of course, you want to get in a full course if you can. So there's a lot of interest in moving it earlier. There are a number of studies, including one at City of Hope, that we're running in bone metastatic castrate-sensitive disease to see whether adding it early will be beneficial. We obviously don't know the answer yet, and right now it's only approved in castrate-resistant, and that's where we're using it clinically. But at ASCO, there was also the question not just of when to use it, but whether to add it to abiraterone or enzalutamide. Neil Shore presented a study from using the Flatiron database of concurrent versus layered, and trying to answer that question of whether the increased skeletal events that we're seeing in ERA-223 with abiraterone and radium, whether that would hold true if you layered. So the findings were a little bit complex in that layered enzalutamide with radium was associated with more fractures, and concurrent Abi and radium was associated with more fractures. But the bottom line, I would say, from that presentation was, if you add the bone support agent, if you're giving them a bisphosphonate or denosumab, you will mitigate that risk. So it's not standard right now to use them together, but certainly if you're going to do it, they got to be on bone support, whether you're layering or using them concurrently.
No, I think that's really great. And I think we learned that, right, from some of these studies the hard way, and we didn't necessarily anticipate this, that this would be a significant, limiting factor to the clinical benefits of combinations. It would make a lot of sense from our localized disease setting that hormone strategies and radiation strategies should play well together. And I think in the bone is where we see these complications in particular, not in other organ sites or other issues. So, I mean, it's relatively well tolerated except for this, and mitigating it with bone strengthening agents is key. And to your chest analogy, I really like that. Thinking ahead, using bone targeted, bone strengthening agents early when you're starting treatment with drugs like abiraterone or enzalutamide in the castrate-resistant setting is probably a really important aspect to this, because then you've had some lead time to build up and strengthen those bones and maybe prevent some of that. And not all the fractures are pathologic. In fact, many of them may be really more osteoporotic. So recognizing that, that strengthening bone, broadly is really important, even if the bone metastases they show aren't necessarily weight bearing. And so I think there's a lot of really important lessons learned from this, and yet it's still an agent, we use. It's been beneficial in many of our patients. Ben, what's the urology perspective regarding radium? Where do you guys see this in the continuum, and how does that sequence in regards to, say, your referrals to medical oncology?
No, I think the critical question and the critical time frame about all the discussions that we've been having about somatic testing, about consideration for chemo, consideration for a PARP now, and consideration for radium are all going to be largely at the same time frame, right? A patient's failing their first oral therapy, eventually we'll be at a different place, but for the next several years, we're going to see those patients that have been on the oral therapies, since diagnosis with metastatic disease, and now are progressing, and they're already at that point, whereas before we sort of had more options up front. And I think radium, the way that I have been talking to people is we always were looking for trials. Now, many of those trials were PARP inhibitors, so we're a little bit beyond that now. But I would say we're going to be looking for PARP, for the defects to treat for PARPs. And for me, radium is right thereafter for the bone dominant patient. I think this is a situation where the clinical presentation of multiple bone mets, we need to follow them differently. We need to prepare them differently. And frankly, as they show any signs of progression and some symptomatology, we really need to look at getting them on radium, because it is a treatment that we found if we delay, we miss, right? They don't get 6 treatments, they don't get the 5, they don't get the benefit. So I think we have to be aggressive in looking for these. And it's interesting to hear, Chuck describe it as imprecise medicine, an imprecise treatment, when it's frankly one of the more targeted treatments that we've had for a long time, because it only goes to predominantly goes to where the cancer is. So, I think it's one that we look very aggressively for. And I put chemotherapy kind of right with it, because Tanya made a good point about the symptom relief from chemo, and I think that's essential. And I think there was interesting, data at ASCO this year about sequencing chemo after radium, and that it's probably fairly safe from a hematological standpoint. So, I think finding that right sweet spot for radium takes effort, but is well worth it for the patient. So, we're actively looking for the patient that can get radium and working hard to get them on it. But it takes some of that. It takes some effort, because this is a subset of patients that are not all your patients, right? This is another one of those subsets you're really looking for.
I would just add that the imprecise comment was, you're right. It's a targeted therapy in a way, but it's not tied to one specific angle.
No, I
biology.
got it. I got it completely. I think it was
Yeah.
totally accurate, but it
Yeah.
is interesting that, you know,
Yeah.
I still think it's one of our more focused therapies that we have.